Welcome back to Yamasatoumi Journal Club. I'm your host Yamato, and today we're diving into a fascinating paper that challenges some long-held assumptions about how doctors think and make diagnoses. We'll be exploring the world of clinical reasoning, specifically the idea of dual process theory, and how it relates to diagnostic errors within our healthcare systems. This paper, published in the Journal of Evaluation in Clinical Practice, really caught my eye because it suggests that maybe we've been focusing on the wrong things when trying to improve diagnostic accuracy. Instead of focusing on correcting biases in our intuition, it emphasizes the crucial role of knowledge and experience.
That's right, Yamato. For decades, the dominant view has been that diagnostic errors largely stem from flaws in our intuitive, rapid thinking, often called System 1. This research challenges that idea and argues that a lack of access to the right knowledge, regardless of the thinking process, is the primary culprit behind misdiagnoses.
To help us unpack this complex topic, we'll be breaking down the paper's main arguments, exploring the research behind it, and discussing its implications for medical education and practice. We'll also be hearing expert commentary from Dr. Satomi, who specializes in clinical reasoning and medical education. Dr. Satomi, can you set the stage for us? What's the background on dual process theory in clinical reasoning?
Dual process theory suggests there are two distinct ways we think. System 1 is that fast, automatic, intuitive process we use for everyday decisions. It relies heavily on pattern recognition and past experience, employing mental shortcuts like using rules of thumb called heuristics.
Heuristics, so these mental shortcuts. So it's like taking a shortcut that might lead you astray if you're not careful.
Exactly. For instance, if a doctor sees a patient with chest pain, they might automatically think of a heart attack based on their past experience. This is a heuristic. However, if they don't consider other possibilities like a pulmonary embolism or even heartburn, they might be falling prey to a bias called availability bias, where readily available information unduly influences their judgment.
That makes sense. So System 1, while efficient, can be prone to errors because of these heuristics and biases.
Yes, and traditionally, the thinking has been that System 1 is more prone to errors because it relies on these mental shortcuts, while System 2, the slower, more analytical, and deliberate process we engage when facing complex or unfamiliar problems, is seen as the error-correcting mechanism. However, this paper argues that this framework doesn't fully capture the reality of diagnostic reasoning.
So how did the researchers approach this question?
The researchers conducted a comprehensive review of existing literature on diagnostic reasoning, looking at both fundamental research in human cognition and studies in clinical medicine. They examined the evidence supporting the claim that System 1 is the primary source of errors and whether System 2 can reliably correct them.
That's a robust approach, examining evidence from multiple angles. And what were their key findings?
Well, they found that the evidence doesn't really support the idea that errors are primarily rooted in System 1. In fact, several studies show that rapid intuitive judgments can be remarkably accurate, especially when clinicians have experience with similar cases.
Interesting. So it's not just about how fast a doctor thinks, but also about the depth and breadth of their medical knowledge, their understanding of diseases, how they present, and how to interpret test results.
Precisely. They also found that encouraging clinicians to slow down and engage System 2 doesn't necessarily lead to increased accuracy. In some cases, it might even increase the likelihood of identifying clinically irrelevant findings as important.
That's counterintuitive to what many believe. What are the implications of these findings for the way we think about diagnostic errors?
It suggests a shift in focus. Instead of trying to debias our intuition, we should prioritize building a strong foundation of knowledge and experience. This means providing learners with more opportunities to encounter a variety of cases and develop a deeper understanding of the relationships between symptoms, diseases, and underlying mechanisms.
So it's more about expanding the knowledge base that fuels our intuition rather than trying to fundamentally change how we think.
Exactly, and this has implications for medical education. We need to rethink how we teach clinical reasoning.
Dr. Satomi, based on your expertise, what stands out to you most about this research?
I think the paper's strength lies in its comprehensive review of the literature and its critical analysis of existing assumptions. It highlights the importance of aligning our educational strategies with a more nuanced understanding of the diagnostic process.
What are some areas for future research that you see stemming from this work? And how might this research influence the way we approach the issue of diagnostic error in healthcare systems?
By shifting our focus from debiasing strategies to knowledge-building strategies, we can potentially develop more effective interventions to improve diagnostic accuracy at a system level.
So let's recap the main takeaways from this insightful paper. Dr. Satomi, what are the key points you want our listeners to remember?
First, the research challenges the traditional view that intuitive thinking is the primary source of diagnostic errors. Second, it highlights the crucial role of knowledge and experience in achieving diagnostic expertise. And finally, it suggests that future efforts to improve diagnostic accuracy should prioritize expanding clinicians' knowledge base rather than solely focusing on debiasing strategies.
This has been a truly thought-provoking discussion, Dr. Satomi. Thank you for sharing your expertise with us. To our listeners, we encourage you to check out the full paper in the Journal of Evaluation in Clinical Practice. We hope this episode has sparked your curiosity about the fascinating world of clinical reasoning and its impact on patient care. That's all for this episode of Yamasatoumi Journal Club. Join us next time for another deep dive into cutting-edge research. Until then, keep learning and keep exploring.